Ja. Sorry. U kan wel plaatsnemen.
Hereby, I open this academic ceremony in which Fatima Elfaki Mohamed will defend the academic thesis Metabolic Syndrome and its risk factors among early adolescents in Khartoum State, Sudan. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Dear Director, dear assessment members, dear family, dear colleagues here and online, good afternoon everyone. In the coming 15 minutes, I will give my key findings on my projects on the metabolic syndrome and its risk factors among early adolescents in Khartoum State in Sudan. So before we start, this is like I will give general background about Sudan. Actually, Sudan is it is the third country in Africa, and it is lying border with 7 countries. And as per 2025, the total population is 51.7 million. So Sudan nowadays facing instability and ongoing conflict. That's why it is affect on the health system, and it is make like the health system is struggle for many times. So I started this research before the war. So that time we targeted the adolescent as during this stage, or this is like a critical period of sharing or of shaping their lifelong, and also it is increased susceptibility to change their unhealthy habits like diet, physical activity, and sleep. And also it is a chance. It is very crucial period, so we can make our intervention during this stage. So we observe worldwide there is transition from the communicable disease to non-communicable disease. And also in Sudan, this is transition and double burden for the communicable and non-communicable disease like cardiovascular disease and diabetes mellitus. So the key factor for this one, it is the lifestyle factors, the diet, the sleep, and the dietary patterns. So this is all leads to the rising prevalence of metabolic syndrome among the early adolescents. Metabolic syndrome, it is a cluster of conditions. It is defined as a collection of metabolic disorders, that is to say, high waist circumferences, high blood pressure, high plasma glucose, and the low level of high density lipoprotein level. So no universal for the definition of metabolic syndrome. In our study, we use the International Diabetic Federation criteria for definition. It is very clear. It is similar to the adult, and it is actually composed of 3 categories. Our target group, it is lies in these second categories, which is 10 to 16. So we define the metabolic syndrome as, first of all, the presence of waist circumferences. It is equal or more than 90 percentile, and presence of any one of the other metabolic disorders, like high triglyceride, it's equal or more than 150. The blood pressure, it is 130 over the 85, and the high density lipoprotein is less than the 40. So although there's a high prevalence of metabolic syndrome worldwide, still in the Africa context, particularly in Sudan, the research is very limited. and also making like gap. So we, in this one, in our research, we analyze or will provide multidisciplinary analysis of metabolic syndrome and its risk factors among the Sudanese early adolescents, and also to give the, to provide the public health strategies. So our objective here, we have like two main objectives. The first one, we are going to assess, or we assess the prevalence of metabolic syndrome among the early Sudanese adolescents. Then to find the association between metabolic syndrome and it is the risk factors like the sleep, the diet, and the physical activity. So to do so, we conducted cross-sectional study in Khartoum State in the primary school. Our sample size was 921, and we used the systemic random sampling technique. So we use the this study instrument. There are four. First of all, we did like interview methods. So in our questionnaire, we use a structure questionnaire, and in the first part, we ask a student about the general background characteristic, then the risk factors, including the sleep, diet, and physical activity. Then the anthropometric measurement, we measure the weight, the height, and the waist circumference. As well, we measured the blood pressure, and we did like biochemical to define the metabolic syndrome, the biochemical assessment. So we asked the student to be fasting, overnight fasting, at least or minimum 8 hours. And then we collected the data this is done by qualified lab technician. So all the standards, the strictly quality protocol followed for the collection of the data, the preservation and transformation for the analysis. So in the lab, these are the our components. We did the analysis for this. First of all, the triglyceride, the high density lipoprotein, and the fasting blood glucose. So our key findings related to our first objective, the prevalence of metabolic syndrome, we found that the prevalence of metabolic syndrome was 2.3%, and it is highly significant among the boys more than the girls. Also, among the obese adolescents, it is highly significant. This is the second objective. In the second objective, we are assess the association between the risk factors and the metabolic syndrome. So this is the first risk factors, which is the sleep. So we use the criteria or the definition of the National Sleep Foundation. Okay. So they define the sleep, short sleep duration for the children and for the adolescents. So our group, it is lying with these two groups. So we use this classification to define the short sleep duration. So the short sleep duration, generally, it was 55%. And the obese adolescent also significantly, they are higher for their sleep duration. And among those who are short sleepers, we found 2.8, they are suffering or they having the metabolic syndrome. So the boys, they are significantly associated with the high density lipoprotein level. On the other hand, the girls associated with the high triglyceride. So this figure shows that the 6.5 hours, those who are asleep less than 6.5 hours, so they showing highest prevalence of the metabolic syndrome. So in our second objective, this is the second part or the second risk factors, which is about the dietary patterns. So 3 dietary patterns are identified: the high protein, high fat, and the Western diet. The second one, the third one is the fruits and vegetables. So the high protein, high diet here, it is characterized by the high variance of the starchy food, the meat, the egg, and the chicken. So the variance here of this one, it is appear like the highest one. It was 25.51. So the high protein, high fat diet and Western diet, they are positively associated with metabolic syndrome. On the other hand, the protein and the fruits and vegetables associated with increasing the prevalence of metabolic syndrome. And boys, they are consume more high protein while the girls, they are consume or they prefer the fruits and vegetables. Also the urban adolescents, they are showing higher intake of the high protein diet. The third risk factors in our second objective, it was the physical activity. So the least active adolescent was showing 71%, and the physical activity was associated with the higher odds of metabolic syndrome and associated with the waist circumferences and the triglyceride. Also in this figure, we can observe that although it is negatively association, but those who are taken the high protein, they are showing increasing in the BMI and the body mass index, while those who are intake the fruits, they are increasing their body mass index. We concluded that the prevalence of metabolic syndrome is 2.3, and the boys higher prevalence more than the girls. And those who are obese adolescents, they are showing more risk factors with the high prevalence of the triglyceride is the most one. And regarding the short sleep, particularly those who are asleep 6.5, they are more susceptible for the metabolic syndrome. And the dietary pattern significantly, it is impact on the metabolic health, and the high protein, high fat, that is increase the risk of metabolic syndrome. And those who are inactive strongly, they are linked with the higher waist circumferences and the triglyceride. We recommend that they are enabling the better habits, the better public health policies and early interventions, and to promote the healthier lifestyle choices to prevent the long-term complications of this metabolic syndrome. And we suggested some of the actions. So strengthen the school health and nutrition programs to raise the awareness about the nutrition and the physical activity promotion so as to encourage them for the fitness, and continue routine for the public for the early screening, and also conducted the health programs about promotion of good sleep habits, and also the collaboration between both the Ministry of Health and the Ministry of Education, and finally to encourage the future research. Before I conclude, I just want to go back to that our problem in Sudan. Still that conflict is going on, and it is really affected and the health system and weakly by the conflict. But still there is the hope despite all these challenges. The peace initiative, the diplomatic effort, negotiation now it is going on, and the most important things the Sudanese resiliences. So by their patience, by their adaptation, they transform all the challenges to be an opportunities. So with sustained efforts, Sudan can recover and thrive. Thank you.
Thank you very much for your presentation.
Thank you.
It's now time to start with the opposition. And the opposition will be opened by the chair of the assessment committee, Professor Krutze, Professor of Behavioral Change and Technology at Maastricht University.
Thank you very much. I normally don't start with compliments for clothes, but you look wonderful, and I think it symbolizes the Sudanese resilience that you were talking about. And then on a more serious note, also my compliments for the thesis. I think it focused on an important health problem. You did a lot of measurements, as you just showed us with questionnaires and anthropomorphics and so on, biomedical measures. So a lot of work, and I'm aware that it's even more challenging in the context where you collected those data. So I think that should not be taken for granted. And on a personal level, I'm happy to see the next generation of PhD candidates from Sudan here. So that's very nice. So also my compliments to your supervisory team. That I think paved the way from Khartoum to Maastricht.
Yeah.
Now to my questions, and I want to start with chapter 1. And in that chapter, you introduced this dull brown white-head rainbow model.
Yeah.
And you mentioned that, and now I quote you, that's a framework for understanding health inequalities by examining the interplay between the individuals and the environment and health. And I can clearly see how this metabolic syndrome is a health problem and how that interact both individual level and environmental level. But I was wondering, can you tell me something about your ideas? How did it help you to understand health inequalities?
Okay.
What are your thoughts on that?
Yeah. Highly esteemed opponent, thank you for your question. Actually, this is why it is the rainbow model. It is examine all the factors, lifestyle factors, and as with our research in the metabolic syndrome, we examine, it helps us to examine the lifestyle factors that may influence on the metabolic syndrome, and also the individual factors, like the age, we have the education and the lifestyle factors that is contributing, and the modifiable risk factors that is contributing in metabolic syndrome, like the diet, like the sleep. So we adopted, or actually not all the factors, it is the multi-level structure, multi-level layer. So we use these factors in our metabolic syndrome.
Yes, so these are all important factors, but
Yeah.
so you see then also differences in health inequalities, for difference between socioeconomic status or educational levels or things like that?
For this research, for now, we did not find the association with the socioeconomic and this, but maybe we consider this in other research. For now, only we consider the risk factors and the association gender-wise, but we are not testing the socioeconomic factors in this one.
Yeah, but do you have any information on that from these youngsters, like where they are from, so to say? Like, with where they're from, I don't mean like where they live, but like their social economic situation, or is this a random sample of people from the region where you sampled, or?
If I understand your question well, so our sample size is from urban and rural area. So
Okay.
there is differentiation for urban in the from socioeconomic point of view. There is a different.
Okay, and would you have any idea, is that the main difference then, the urban and the rural, or would you say there are other factors that also have to do with like poverty or being rich or wellness?
For prevalence of metabolic syndrome, we found the urban is highest prevalence of metabolic syndrome. So, and urbanization as well in Sudan. Nowadays, urbanization everywhere, not only among the urban one. So, even for people, the socioeconomic level may be low. It can be also one of the reasons that is to increase the level of metabolic syndrome.
Yes. All right. And then another thing, and I think you already mentioned that elaborately in your presentation as well, you found the difference between boys and girls. Mm-hmm. That was interesting, because if you look at the older segment of the population, like the older women, then it's the other way around, right? It's the older women tend to have it more than the older men. Yeah. And that has to do with hormone levels after menopause and so on. So I was then thinking, do you have also like a biological explanation for the boys, why they are more prevalent than the girls, the young ones, I mean?
Mm-hmm. So one study, they actually our results, it is similar to one study. That is the boys, they have higher metabolic syndrome, and they related this, maybe it is related to the sex hormonal changes during this puberty stage of life. Although in Sudan, one study previously conducted, but not the same age group, they found that the girls, they have more significantly, not significantly, but they have more prevalence of metabolic syndrome more than the boys. But in our study, we find boys more.
Yeah, yeah. And you, in your first answer was, part of it was the sex hormone you said?
Yeah, this one.
I think also somewhere you refer to puberty, for example.
The puberty stage, yeah.
And of course, I know that there is differences in terms of timing of puberty between
boys and girls. Yeah.
Girls are literally a bit more grown up at an earlier age. But then I was wondering, if you look at table 2 on page 54, there you have made the distinction between boys and girls. And you also make the distinction between like 10 years old, 11 years old, 12, 13, 15, and so on. But have you also looked at if those two cross, so to say? So how is that, like, do you also see the development of boys then being later, and girls, or something like that?
Yeah, excuse me.
Oh, you don't have a book? Okay, that's...
Yeah.
Yeah, so you see that you have the percentages for boys and girls, and you also have the percentages for 10, 11, 12, and you see, of course, if they... you see the developments there over time, if they grow older, but I was wondering, did you also look at the development for boys and girls separately? Like, do they differ? Do you see that also in a pattern, that boys develop it later than girls?
Can you read this one?
Yeah, you have the boys and the girls.
Yeah.
And you also have all the ages.
Yeah.
And I also did you look at how these two cross? Like boys of 10, 11, 12, 13, 14, 15, and girls of 10, 11, 12, 13, 14, 15.
Yeah.
Was it then also later for the boys that they start developing it, or?
Yeah, and age group, we observed that those who are older, their prevalence of metabolic syndrome is more among the older one.
Okay, yeah, so it's more if they're older, but
Yeah.
it's also more about boys that are older, and then boys get it later, or then, or?
Boys more than the girls.
Yeah, in general, but also if
Generally, yeah.
And
Yeah, but in age-wise, if we look to age-wise, we found that the girls, yeah, there is differentiation between in the age group between the prevalence of age group and I mean among their age group.
okay, but the difference, you didn't look at this age, then
No,
you don't have a separate...
no, we don't have like for age group. We just make it like generally the boys and the girls, but we did not test the age group, the prevalence among age group.
Yeah, that might be interesting to look at this puberty timing, whether that, or at least an indication to follow up that. Okay, thank you.
Okay, thank you.
Give the word back to the corrector.
Thank you very much, Professor Krutke. The opposition will be continued by Dr. Gubbels, Associate Professor of Health Promotion at Maastricht University.
Dear candidate, I would also like to congratulate you on the nice work and also for your team. It's a very interesting topic in a very challenging context, so my compliments to the work that you did. It was a lot of work. And I enjoyed reading the thesis. I thought each of the chapters were, in itself, they were interesting and relevant. But I also got the feeling that it was a little bit of a missed opportunity that you didn't look over the different behaviors. So you look at sleep and physical activity, and diet, but not at the interaction between those behaviors. So I wondered whether you explored whether there is an interaction between these behaviors, and whether you can hypothesize on what you think you would have found if you would have looked at them combined.
Hi, esteemed opponent. Thank you for your question. Actually, we did separate these risk factors differently because their influence on the metabolic syndrome, it is separately or differently. So, for example, for instance, we will find the association with the metabolic syndrome with the high-density lipoprotein. On the other hand, the association, it is more among the dietary patterns and the high glucose or high plasma glucose. And also for the intervention, that is why we did like separately. So for intervention, we can tailor like intervention specifically for those, mainly in our situation now in Sudan, because the management of this non-communicable disease, it is a struggle because we have many problems. So the tailored intervention separately, it will help them, but for sure, we can make like combine for all the risk factors because the three risk factors, they are interrelated to each other and contributed to the metabolic syndrome. So we can do the research, or we can do the multifactorial study for all these risk factors together. And we can use also the data for longitudinal study to make it like a combined one.
Mm-hmm. Did you look at it already in your data, whether they are interrelated?
For now, we did for this separately, but we'll thesis will do in future research. We'll do this combine factors all together.
And what do you expect to find when you look at these combinations?
So the three factors, they are interrelated, and three of them, they are contributed. But it may be different according to the population will use, according to the that is our the outcome we expected for them. Maybe different will come. So and for now, as I mentioned that every risk factors, it has its own association with the components.
Do you think one behavior can compensate or protect for a bad score on another behavior?
The three of them contributed in the metabolic syndrome.
So if I am very active, I can also have a very unhealthy profile, dietary profile, and that my risk will not increase. Do they compensate, or do you think each in themselves they contribute?
They have their interrelation in the contribution. Three of them, they have their effect and the components. But as I told that it depends on the population, or it depends on the outcome. For example, we'll find the obesity as a major risk factors, or it is the most important risk factors. Okay, and on the other hand, maybe we'll find those who are physically inactive, as you mentioned that. Maybe also it may be for them. It depends on the outcome. That is we set for the purpose of the study.
And does this occur a lot in Sudan also, this clustering of behavior? So the youngsters that are inactive are also the youngsters that have an unhealthy diet, or do you have any idea on that?
For Sudan, for sure, this is for the physical inactivity or unhealthy diet, it is everywhere. Also in Sudan, it is the same situation for people, and now we found that the physical inactivity, the percentage is 71.4 for those adolescents who are physically inactive. And also regarding the dietary patterns, we found those for example, the boys and the girls is the boys little consumption of the fruits and the vegetables. And also regarding the sleep, we observed that many of the adolescents, they are sleep less than the 6.5. So this is also in the Sudan, like the physical inactivity or the bad dietary patterns for them.
Okay. I'd like to also ask you a little bit about chapter 3. It's about sleep. You already said there's a lot of youngsters not sleeping enough. But I read that you assessed sleep by self-report of these children as an average over the last 6 months. Can you reflect on the quality of that measure and whether it's precise enough to find those effects?
For the sleep, we did not check the quality of the sleep. We only check their sleeping during night, only the hours during nights. And according to this one, we classified the short sleep duration. But we did not check the quality of the sleep.
But what do you think about the quality of the way you assessed sleep? So not the quality of the sleep, but the assessment of sleep, because they self-reported. Yeah. It's difficult to report how much did I sleep.
Yeah, it is one of the actual limitations, that because sometimes they are not remember this time of the sleep. But generally, they're according to our result now, these 6 hours. This is, if we can think, it is not good quality for them, because some of them like to sleep only 6 hours per day.
Yeah, and you then asked it for over the last 6 months, and in your general introduction, you already explained that sleep variability is also very important. So it needs to be consistent, not sleeping 4 hours for one night and 8 hours for the next one. So can you reflect on what the way that you assessed the sleep, how this could have influenced your findings?
Actually, sleep, this is short sleep. It is it has like not direct effect on the metabolic syndrome, but those who are like a short sleeper, they are like staying all the day or all the nights. This is like they are inactive. They are maybe consume the foods high in this fostering food. This is may leads to increase their weight, or as we define the metabolic syndrome, maybe increase their waist circumferences. So it will affect on the prevalence on the prevalence of the metabolic syndrome.
Mm-hmm. Yes, but in the general introduction, you made a point out of sleep variability being important. So it's not just important the average of sleep, but also whether it's consistent, whether it's not different on different days. And you didn't take that into account in this study. Do you think, would you change it? How would you in a future study assess sleep if you had to do it over again?
Yeah, this is now for this assessment of sleep. We are not test these differences between the weekdays and the weekend for them. So in the future, maybe we'll consider this one because we're just asking the on night. But we are not make differences between the weekend days because weekdays are different from the working days for them during school. So in the future, we consider this one and also maybe the quality of their sleep.
Mm-hmm. Would you still choose for self-report by the children?
We'll do another way for this. We'll do like interviewing for them.
Mm-hmm.
Yeah.
Mm-hmm. And you would again choose for doing that way, interviewing the children and let them self-report on their sleep.
Yeah, we'll use the. I think that one of the standardized that questionnaire about the sleep quality. We'll think to use that one in our future research.
Okay. Mm-hmm. Thank you.
Thank you, Dr. Gubbels. The opposition will be continued by Dr. El Musharraf, Associate Professor in Public Health at the University of Birmingham, Dubai, United Arab Emirates, and he's present online.
Oh, sorry. Yeah, can you hear me now? Perfect. Dear candidate, your thesis does an excellent job highlighting the lifestyle-related risk factors, particularly diet, physical activities, and sleep, that are contributing to the rise of metabolic syndrome among early adolescents in Khartoum. I really enjoyed reading the thesis, particularly the last chapter, the discussion, and the recommendation. Given Sudan's ongoing war and severe disruption to school infrastructure, food systems, and community services, how do you propose applying your findings to inform public health intervention in the current humanitarian settings? Or maybe what can be done now to improve adolescent health in the current situation?
Hi, esteemed opponent. Thank you for your question. As you said that given this ongoing conflict in Sudan, actually our readiness for this one is very limited because of the situation now in Sudan. But for the strategies for this one to implement, for now in Sudan, we cannot start this one, but we are ready with our data, with our results all. And once the Sudan is stable, we can start our strategies to implement our strategies, and also with the contact with the health accessibility to these strategies or implementation, and conduct like maybe pilot or our intervention studies later. But for now, we cannot, because of this instability now in the Sudan, we cannot conduct or we cannot, but we are ready for the, with our findings for this implementation later when the, everything is settled and safe in Sudan.
But currently, the Minister of Health is doing great work in different parts of Sudan. There are many international organizations and UN agencies are currently working in Sudan. So based on your research and findings, what are your recommendations to them to do during the current situation?
For now, even this work for this organization, for Ministry of Health, is still the condition as unsafe for them. So we can start by like the awareness or like education for people, but we cannot start because even these places now, they are started, the NGOs started the work, or the Ministry of Health, even these places now, they are people return back to Sudan and started this one, but still the humanitarian, still the crisis is still going on in Sudan. So we can share or we can participate with them as like just to give like, as I mentioned, that the awareness or health education, but we cannot start our implementation at this time.
Okay, looking forward, and considering Sudan's future rebuilding efforts after war, when peace comes and then starting, the rebuilding, how can your research be translated into policy or programs to protect adolescents from non-communicable diseases? So then this will be for the next chapter in Sudan. So what are your recommendations then?
Suggested many recommendations and strategies that is after the settlement, like program of the community health program and the strength of the nutrition and health program in Sudan, promotion of physical activity. This is related to our findings or related to our objectives of this study, and also the collaboration, as I mentioned, that is between the education and the health. Both together, and the community also participation. It can be also one of our strategy in the future.
Thank you very much. That's from my side.
Thank you very much, Dr. El-Musharraf. We now continue with Professor Pavlova, Professor of Health, Economics and Equity at Maastricht University.
Thank you. Dear candidate, I would like to congratulate you and your supervisory team for this valuable dissertation. You have investigated a topic that is of global importance especially the risk factors that are linked to the syndrome of the metabolic syndrome. Although you focus on risk factors among adolescents in Khartoum state in Sudan, the evidence in your dissertation and the research that you offer will definitely inform decision makers also in other countries and will raise interest of researchers all over the world. Because it is a very complex medical condition and there are many different challenges that need to be understood and also addressed. I would like to discuss with you some points in your research for this dissertation that is linked to causality. So, studying causality is a dream of every quantitative researcher. But in your dissertation, as you point to several, you have been very careful to point out the rich analysis that you are not able to study causality, but your analysis is limited to associations. And indeed, associations are less informative because they do not really pinpoint to the factor that need to be addressed to make change. So I was wondering what was the reason that you limit yourself to associations. Was it that a conscious choice, or is it because of data, or because of specific analysis? How would you explain that? Why limiting to association and not going a step further, maybe try to study causality?
Highly esteemed opponent, thank you for your question. Actually, our plan from beginning to do it like this is quantitative and qualitative as well. But as you mentioned, one of my personal reasons that is for this data collection in Sudan, and I'm not settled in Sudan, so I have to go to Sudan, and I'm working in other country. So this is one of my personal reason for that one. And another things, now we make this association like as a base for us for the study, our findings, all these things. So we'll continue in the future, okay? And we'll do more study, more investigations, and advanced analysis on this area.
Okay, so that's so fine. Indeed, many researchers are not able to establish causality, and then they write very valuable pieces of work also based on associations. But how should we then interpret the results? If these are associations, if the patterns of sleep, food, and physical activities that you study as risk factors, if they're only associated with the metabolic syndrome, what are then the causes that we need to address? Or are these factors also causes, but you just could not establish that? Are these behavioral factors also the causes?
Yeah, actually, because in this research we could not find the causal factors. It is only like association, and this is one of our limitations in the study. And but in this stage, at least we have the findings for the association to start our. We can do like a pilot study according to this one, and we can do the intervention for this one, and we can find like more results in this one, and for the three factors, not all. And the next step will be like these strategies, mainly for the education or for the raise awareness and these things. But when we conduct it, or the next step for us, the pilot study, then we can move over on this one or more, and we can do our intervention. At least now we have the baseline, okay, for this study.
Okay, so the interventions that you mentioned, should they address the sleep, food, and physical activity? Is this what you propose, or there are some other factors that need to be addressed to reduce the prevalence of metabolic syndrome?
For now, these are the three factors, but we look for the that is the socioeconomic factors as well. We can include it in our study later.
Okay.
But these are the three major factors for us for the prevalence of mixed.
So you propose future interventions to focus on those three factors. Okay. I also wonder how feasible is to do that in the context of Sudan or in another country in the region, if we consider that the current situation in Sudan now is very dramatic. What about, if we take another country in the region, how feasible is to address the patterns of sleep, food, and physical activity?
Okay, as I mentioned that for Sudan, our readiness is limited for now. Okay, we cannot start this one, we cannot do this one, but in the future, we'll, inshallah, we'll do these things. But in other region, in this, I think this is like, they can do it. For the physical activity and for dietary patterns, this intervention is possible mainly during this age group. This is like primary and intermediate school. So in other region it can be done. But for us in the Sudan, it can be like later, like in the future researches, but not for now.
Would you think that this will be effective interventions, considering the adolescents nowadays have different kinds of interests than being physically active? And
yeah, sure. We have like, I will just share with you my experience. One of the research for the intervention we conducted in Saudi Arabia, that's intervention. It is not like, it is only for 6 months, but we targeted the school children for diet and physical activity during these 6 months. But it was effective for them.
And do you think that the same experience can be also in Sudan, assuming that we have usual conditions and not the current situation?
For intervention,
Yeah,
I mean that.
The same intervention?
Yeah, we can do it, yeah, we can do it in Sudan. But not now, at this moment.
So imagine that I see that we have some more time. Yes. So imagine that you have a possibility to continue your study, and you have a big research grant. What you will do differently? Would you do the same in more countries, or will do something different in Sudan? What will be your approach for studying the same topic with new research funding?
Yeah, for now this one, we just selected 2 localities. In Khartoum state, there are 7 localities. We are just selected 2 localities for this one. But if we have a chance for more, we can expand this area for study, not only in Khartoum, but all over the states in Sudan, not only in Khartoum state. And we can increase our sample size as well.
Would you expect differences across the states?
We can, like now Khartoum, different, we like Eastern Sudan, Northern Sudan, for every state or every, like this one is different from the others. So maybe we'll find difference because now those our target group only from Khartoum as a capital. So for example, the adolescent in the western, not western, in the eastern Sudan and the western Sudan, mainly the western, maybe their lifestyle different from the adolescent or from the our children in Khartoum as state one, as capital state.
Okay, thank you very much for the discussion, and I give the word back to the director.
Then the next opponent is Professor Danieli, Professor of Nutritional Epidemiology at Maastricht University.
Thank you. Dear candidate, I'm really honored to be here on invitation by Professor Kremers. And it reminds me of my time when I was in Khartoum at Awad University for women. It was in December 2016, was actually also mediated by Professor Kremers because he could not go, and then asked me if I could replace him at a conference on malnutrition. So I was there, and I was really impressed also by the ethical level there with Congress on malnutrition, but also, just to mention an example, I gave a workshop on the role of women, including their spiritual role in the field of Sudan and in nutrition. I read your thesis with great joy, and I think you did a great job, especially considering, it has been mentioned already, the data collection. If I remember, if I calculate well, it was during the civil protests in Sudan, so it was not an easy period with backlash. And I also admire your language, which is completely different from Arabic, but it was really written in good English. You were very courageous to take metabolic syndrome because the word metabolic syndrome is actually a contradiction. It's not really a syndrome because a syndrome is also always a cluster of symptoms which always go together. In this case, it's different combinations which are statistically clustered but in different combinations. So it's not really that in each person which is defined as having metabolic syndrome, it's all the same symptoms. I like your description of the metabolic syndrome, which considers this problem actually. So you problematize it in a good sense. I have a number of questions, of course, and especially related to chapter 4, which is on diet. I found it very interesting that you found associations between a food frequency questionnaire with only 14 food groups, which is very crude, and still you find associations with metabolic syndrome in the sense that one would expect. We'll come back to that later. My first question is, your fieldwork was done in 2018, 2019. Do you think we are 6 years further, 6 to 7 years further now, in time with 2025, and there's a civil war? Has anything changed in relation to nutritional status, communicable, non-communicable diseases, but especially in relation to nutritional status since then?
I'll stay on point. Thank you for the question. Actually, change is there. This is before this one, the Ministry of Health in Sudan, they are struggling with the management of non-communicable diseases.
Yes, it was before the
because
civil
of
war,
yeah,
it
because
was
of
not, it was not before the civil strike. The civil strikes were really going on at that time.
yeah. This is before the conflict.
Yeah.
Before the conflict, they are struggling with the management of non-communicable disease because of many reasons: inadequate facilities and the infrastructure for the health system in Sudan. Recently, now the conflict, this is added to that struggling for them. But before the war, they are struggling with the management of this one in the health system, or the management of the non-communicable disease. So now, for this conflict, it is making like, I will not tell more difficult, but it cannot be possible at this time. But for sure, during this period of time, changes occur for people, and many people, they are displaced from their houses, their countries. So definitely their habits, it is changed as accordingly, and they are living in other countries. And even those who are still living in Sudan, they are suffering from even some people. They cannot find to eat food. So definitely their habits, definitely their diet,
Do you
their
think
style change.
that would mean that metabolic syndrome has gone down temporarily, for instance? Because if there's more malnutrition and underweight, then you would...
Yeah, now many cases of malnutrition and underweight because of food insecurity, because of this intake of food. It is now a million of cases of malnutrition.
Then I have a question to your study. I actually wondered, you describe your sampling technique quite detailed, but there's one factor which is missing, which is how many people were invited and how many people actually participated in the study. And if I look at table 1 in chapter 4, you could have a look at that. What I noticed that, for instance, if you look at the educational level of the father, then there are 206 people, 206 fathers in the urban area with university or postgraduate education. And if you add up all the others, that's 236. So that means that this is a very, very highly educated population. It cannot be representative for the urban situation of Khartoum. And I was suspecting that perhaps, because you had to give, the participants had to give informed consent, both the children and their parents. Could it be that many of the lower educated people did not give informed consent, or is there another reason?
Not the reasons for the consent. Actually, our sample size, more than this 921, it is was 1,036. But because some of the students, some of them, they cannot tolerate the fasting, because it is for us.
Cannot tolerate, sorry?
Fasting. Because for us, this is we cannot define for the definition of metabolic syndrome. The first things that is the three components. This is required sample collection, blood collection, and that is required like to be fasting at least 8 hours. So for them, some of them they cannot tolerate this fasting. Some of them they are fearing of fasting. Okay, yeah, and that is why. So for those who are, we did not find their did the biochemical, so we excluded them from the. This is the main reasons for them for the sample size to be less than what we calculated in the beginning.
Okay. Yeah. Do you think this would have influenced the associations which you described in chapter 4, the association between diet and metabolic syndrome, the fact that it was not completely representative?
For diet, we found that for adolescents who their parents' educational level is high, their consumption of diet, mainly the fruits and vegetables, is more than the other group.
Mm-hmm.
So this education for them, their parents' education level, it will affect the occurrence of the metabolic syndrome.
Yes, but what I mean, would the association be different if the sample was representative?
If more sample size?
No, if it was representative truly for this population.
If I understand your question, that is if the sample size, the original one, that's we calculated in the beginning.
Let me help you a bit. If you have a description how many have metabolic syndrome, then the effect would be that, for instance, if there was more in reality, if there were more lower education, then it could be that metabolic syndrome would be higher than the percentage you found. But for the association between educational level and metabolic syndrome, or between diet and metabolic syndrome, if you adjust, which you did, it has no effect. So the results are valid despite of this. I also wanted in table 2, you mentioned the load of the different foods on the dietary patterns. You have 3 dietary patterns. But in the table there are a number of places which are empty.
Yeah.
And does that mean that, for instance, on the high protein, high fat diet, that fast fried food has a loading of 0? Or is it just that you find the loading that's relevant and you have to mention it?
Yeah, exactly. It's not like it is 0, but it is like the variance of this one. It is high in for example, the meat. The variance, it is high in the group of the high protein, high diet.
Okay.
That is why I make it.
I understand. But it would then be better for the reader if he gets the numbers also in the table, so that he can see.
Thank you for it.
I find your results really interesting. Girls consume more fruit and vegetable than boys. Urban more high protein fat than rural, which is logical. And also the association with the metabolic diet, so with the metabolic syndrome. So I found really interesting to read results. Finally, I have a question related to one of the propositions. proposition 9. Could one of the parents read it?
Oh, ik kan blijven. Ja.
We have been endowed with just enough intelligence to be able to see clearly just how utterly
Last!
Well, I'm afraid this has to be the end of the discussion, but you can discuss this later on, what you want to ask.
I thank you very much, and I give the word back to the rector.
Fatima Awad Mohamed, the time appointed for defending your thesis has passed. The degree committee will now discuss the quality of your thesis and your defense. I request that you and your company leave this room. After the deliberation, the beadle will come and collect you to return to this room.
Wilt u gaan staan?
Accelerate.
Ja. U kunt wel plaatsnemen.
Fatima Awad Mohamed. The degree committee here present has assessed the quality of your thesis and of your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kremers is authorized to confer upon you this academic distinction in accordance with Dutch University custom. I invite your supervisor to now take the floor.
Wilt u gaan staan?
First, I have a question for you.
Yeah.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority invested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you Fatima Awad Elkarim Elfaki Mohamed, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Here it is. Just show it to you.
Yes.
Yeah, if you stand there with some
cameras, but
yes, landscape and portraits, very good.
Maybe you Baroness can.
Thank you.
So, Fatima, dear Fatima, Dr. Elfaki, congratulations with this great achievement. I'm honored to be the first person to congratulate you and to call you doctor. I will speak this Laudatio also on behalf of Aziza Moukayer and Mohamed Moukayer, your very proud co-promoters. You have really deserved that certificate, and you've worked really hard for it. Persistence, that is the right word. You truly persevered in reaching this point. Since I met you for the first time, approximately 10 years ago, introduced by Aziza and Mohamed, you impressed me with your motivation to make this endeavor a success. Very motivated and persistent, but not in a demanding way, but more so in a timid, sensitive, and elegant way. Eager to learn, willing to move forward, but always remain calm and respectful in communication with the people around you. And also your sense of humor. Aziza called it a timid sense of humor. I like that qualification. Made it really pleasant to supervise you. But there have been quite some hurdles to overcome. It started approximately 10 years ago with getting approval of your study at the Ministry of Health in Sudan. Persistence was needed there as well, to convince the ministry that giving clearance for your study was a wise thing to do. And the process lasted very long, but in the end you managed and you could start your data collection in 2017. And gathering the data was an immense undertaking. It has been mentioned a couple of times. You gave the committee some insights in the process in your presentation, but it remains difficult to imagine for us in the Netherlands how challenging this was for you to do all the measurements in a good and reliable and valid way. That was a masterpiece in itself. You were the first to gather such a big data set in Sudan that consists of such a large variety of subjective and objective measures in Sudanese children and adolescents. And during your PhD trajectory, you had to overcome many challenges. Next to the challenges in writing scientific papers, there were sad family matters, and of course the ongoing war for the past years. A terrible conflict in your home country, and you devoted much time and energy in supporting affected friends and family. It was impressive for me to experience that the conflict seemed to motivate you even more to execute your studies, based on your genuine belief that your work has true importance and value for the people in Sudan and beyond. And the analysis of the data and the writing of the papers you did many times while staying in Maastricht during your holidays. I think you hardly had any true holidays in the past 10 years during your PhD period, because you had a very demanding job in Jazan, Saudi Arabia, that left you no time at all to devote to writing the thesis. Luckily, you could come to Maastricht with your husband, Hussam, also the photographer today. Most of the times he was there as well, so you could at least have some time together in Maastricht while working on your PhD. And I helped you a bit by having him writing a thesis as well, so he would not distract you too much during the writing of the papers. It was always very funny to have both of you in my office to talk about your PhD studies. When I asked who wanted to be first to discuss the process and receive feedback, it was always you.
Yeah.
It was very clear to me who is the boss. And also in receiving the certificate, you are the first. I think you gave a great example today and in the past to Hussam in how he could also reach the point where you are in the academic world right now. For now, Dr. Elfaki, I congratulate you once again, also on behalf of Aziza and Mohamed, with this great achievement. Enjoy the moment.
Thank you.
Dr. Elfaki, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. It's an important day, I think, for you, and I understand that probably in some weeks, years, months, there will be another one. So maybe we will see you here again. Yes, I also would like to congratulate your husband and probably also your family that is watching online in Sudan or maybe somewhere else because of the situation. I'd like to congratulate your supervisors with this nice degree. I'd like to thank the members of the degree committee for the work they did, their presence here. Dr. Al-Musharraf especially, thank you very much for your contribution and for the time you have invested in this PhD ceremony. Maastricht University really appreciates that. Yeah, I hope that you also enjoyed the defense. Maybe enjoy is a little bit too much, but you feel happy about the way it went, and I can tell you that the committee was satisfied with the way you defended your thesis. You're clearly quite knowledgeable on the topic of metabolic syndrome in Sudan, And I understand that despite all the difficulties, you have plans to continue and see that the situation will improve also for adolescents in Sudan. Yes, I think we have come now to the end of the academic ceremony, and I close the ceremony.